Hello and welcome back to our channel. Today we're tackling a crucial topic that, while more common in developing nations, still carries significant global health implications. So, what is rheumatic fever? As our text rightly states, it's an inflammatory disease that can tragically affect the heart, brain, skin, and joints. It's a disease born from poverty and overcrowding, areas where Group A streptococcal infections, the common strep throat, can run rampant. The pathogenesis is fascinating in a challenging way. Your body produces antibodies to fight off that strep infection in the throat. But in a cruel twist of fate, these antibodies can get confused. They cross-react with your own tissues, launching an attack on the heart's lining, the endocardium, the muscle, the myocardium, and the sac, the pericardium. This friendly fire also targets the joints, the skin, and even the basal ganglia in the brain. The heart, particularly the left side, often bears the brunt of this assault. This can lead to serious long-term damage, causing the mitral and aortic valves to become narrowed, a condition we call stenosis or leaky, which is known as regurgitation. Now, how does a patient with rheumatic fever present? We use a system called the Jones criteria to make a diagnosis. Think of it as a checklist. To diagnose rheumatic fever, we need to find either 2 or more major signs, or 1 major and 2 or more minor signs. Crucially, this must be paired with evidence of a recent Group A strep infection, like a positive throat culture or elevated anti-streptolysin O (ASI). Let's break down the major criteria, the big red flags. First, carditis. This is inflammation of the heart. Patients might complain of shortness of breath, chest pain, or palpitations. When we listen with a stethoscope, we might hear a new heart murmur. But I want to add a critical point here from the latest guidelines. We must perform an echocardiogram. An echo can detect subclinical carditis, which is inflammation you can't hear with a stethoscope, but is a confirmed major sign of the disease. Second, polyarthritis. This is a classic feature. It's an acute, painful inflammation that migrates from one joint to another. One day it's the knee, the next it's the ankle. It's often asymmetrical and responds dramatically to aspirin. Third, pseudonym chorea, also known as St. Vitus dance. This is a neurological sign. It involves jerky, purposeless, involuntary movements, especially of the hands, feet, or face. Fourth, erythema marginatum. This is a very specific type of rash. It appears as reddish macules with pale centers and sharp snake-like borders, usually on the trunk and limbs, but almost never on the face. And fifth, subcutaneous nodules. These are firm, painless, small bumps found over bony areas or tendons, like the elbows, knuckles, or spine. The minor criteria are less specific but still important pieces of the puzzle. They include fever, joint pain, or arthralgia, which is less severe than arthritis, a history of a previous episode of rheumatic fever, a high white blood cell count, leukocytosis, and specific changes on an EKG, like a first or second degree AV block. So how do we treat this? The immediate goal is to eradicate the strep bacteria. The treatment of choice is an injection of benzathine penicillin. Oral penicillin can also be used. For patients with a penicillin allergy, we turn to erythromycin or cephalosporin. Then we manage the symptoms and complications. For the painful arthritis, aspirin is highly effective. For carditis, which is the most serious complication, we use corticosteroids to suppress the inflammation and protect the heart. But treatment doesn't end there. Prevention is paramount. We have to prevent this from ever happening again, because recurrent attacks cause progressively worse heart damage. This is called secondary prevention, or prophylaxis. This involves giving regular long-term antibiotics, usually monthly injections of benzathine penicillin. The duration depends on the severity of the disease. If there was no heart involvement, prophylaxis continues for at least 5 years or until the patient turns 21, whichever is longer. If there was carditis but it resolved without permanent damage, the duration extends to 10 years or age 21. But if there is persistent rheumatic heart disease, prophylaxis must continue for at least 10 years after the last attack and until at least age 40. For many with severe valve damage, lifelong prophylaxis is necessary to protect their heart. Did this video help clear things up for you? Let me know by hitting that like button. And if you want to keep learning with me, make sure you subscribe and click that bell.